you have tried to cover each and every aspect, but as you have tried to cover that there are different type of presentation of abdominal tuberculosis, and that's why probably different treatment has to be selected based on the acute presentation or chronic or subacute obstruction or perforation. Bleeding is a little bit less common. Obviously, internal fistulae, all these things are very common. I would just add to your what you said that sharp dissection is what is required in a patient with when you are entering the abdomen in a case of cocoon, and it is very important to be very patient, and no finger should be used for the dissection. There are multiple evidence. There are multiple reports earlier, many years back, about the finger blunt dissection, we say with sharp dissection, and the dissection by the Mayo Caesar, very patiently, slowly going in between the two bowel loop, trying to make a plane and be very slow. One more thing I used to find entering into the preperitoneal space and taking bowel in front of you and then trying to do slow adhesiolysis. Second important point is because entry is also very difficult sometimes in tuberculosis. Second important point is about there is a perforation. I think you highlighted. We should reiterate that in a perforation case, these people are nutritionally compromised. You must do a ostomy formation rather than trying to do any type of anastomosis, and then go start ATT and make the patient nutritionally viable for the surgery. Then definitive surgery can be done. And the rest of the things are, I think, covered everything. So, Kapoor sir, any important
One point I would like to mention for students and young colleagues that if you are not sure by histology that it is tuberculosis, especially in an ileocecal mass lesion, where there is a possibility that it may be tuberculosis or malignancy, then it is better to do a formal right hemicolectomy as if you are dealing with malignancy, because it may be an overkill if it turns out to be tuberculosis. But on the other hand, if you do a limited resection and it turns out to be malignancy, then your treatment was not complete. So that is one. And second, if you're doing a stricture plasty, you must always, when you open the stricture, you must always take a biopsy from the edges of the opening so as to confirm your diagnosis. Mohit, would you like to make a comment on this? That earlier, when we used to use streptomycin and PAS and other drugs, it was a very strong belief that anti-tubercular treatment will cause fibrosis and will lead to stricture formation and will lead to adhesion formation. Is it true that with the newer anti-tubercular drugs, the healing is not by as much fibrosis as used to be earlier? Is that true?
Sir, the thing is, there is no newer anti-tubercular therapy. Today, we will discuss the drug-sensitive tuberculosis therapy, sir. Second thing, we didn't discuss the MDR tuberculosis because only 6.8% of the total cases they will classify as an MDR, sir. We have data of 6.8% of the patients converted into the MDR abdominal tuberculosis because they have concomitant other part of the involvement is there. Either it is tuberculosis meningitis or pulmonary tuberculosis or genitourinary tuberculosis. So there is not a thing. These are the old drugs which we are using in the right now, but there is a definitive guidelines. Before, we don't have any specific guidelines when to stop the therapy, when to start the therapy, when to follow up the patients. But right now we have clear guidelines. You have to start the anti-tubercular therapy in 2 phases. Intensive phase of 2 months. We can extend up to 4 months, depends on the clinical basis or radiological basis. And we have to continue with the intensive phase of the 4 to 6 months maximum. If the patient is streptomycin, sir, streptomycin is not indicated unless we need to modify the drug regimen, especially in the CLD patients. Sir. We are not supposed to start the streptomycin if the patient is drug-sensitive abdominal tuberculosis. We have to give H, isoniazid, rifampicin, pyrazinamide, and ethambutol. PAS comes in the MDR treatment regimen, sir. but still MDR treatment regimen is totally changed right now, sir. And there are a lot of debate, and we can discuss it. 1 hour is still in 1 hour we can't discuss the MDR tuberculosis, sir. So today we just discuss the drug sensitive tuberculosis. Pass initially we give in the drug resistant tuberculosis. Still we are giving in drug resistant tuberculosis, but not in drug sensitive tuberculosis, sir.
The other point from our surgical point of view, many of these patients, we put them on tube feed, either a nasogastric, nasojejunal or feeding jejunostomy tube. So what is the site of absorption of these drugs?
So the thing is, you can give all the therapies through the nasogastric tube also. Because we are not giving injectables. These all the drugs comes in the, especially in India, sir. Sachet form is also there in India also, but prefer oral tablet forms. We can crush the drugs, we can give through the nasogastric tube, sir. Second thing, the absorption part, gastric absorption is there and intestinal absorption is there, sir. The main things happened in the metabolism part, sir. Isoniazid and rifampicin metabolized by the liver, while excretion of the ethambutol and pyrazinamide is to the renal excretions. That's why we modify the drug in the CLD patients and CKD patients. So we can give ATT through the nasogastric tube, percutaneous jejunostomy tube also.
And maybe I missed that part, maybe you did mention, but maybe you can mention it again, that before starting ATT, we must get an LFT done. And when should the first LFT be done? After
Yes,
how
sir.
much
Yes, sir.
time?
According to the guidelines, sir, 4 weeks.
4 weeks.
But if the patient is history of the chronic liver disease or history of recurrent jaundice is there, then better ask the patient to come 7 to 10 days with the LFT reports. If the patient is suspicious of any liver disease.
Dr. Sitaram, you would like to say something?
Yes, thank you. The problem of entry into the abdomen has already been mentioned. It can be very easy, it can be extraordinarily difficult, and a wide spectrum in between. So when you enter the abdomen in these patients, it's very important not to cause bowel injury, because you shouldn't add to the patient's problems by creating bowel injury which goes unrecognized. That's the first comment I want to make. This has already been mentioned. Second comment I want to make is, if you do a laparoscopy or a laparotomy, in order to get a diagnosis, you must make sure at the end of your procedure that you have sufficient tissue to make a diagnosis. Because you shouldn't be in the situation of telling the patient 1 week or 10 days later, I still don't have a diagnosis because the pathologist has said we are unable to say what the disease is. So frozen section in these patients should be done. What happens if you don't have frozen section facility? I don't have an answer to that. But it is better that in a place where frozen section facility is available, make use of the facility, get a commitment from the pathologist that the tissue is sufficient, and you have a diagnosis at the end of your operation. Third comment I want to make is, in situations when there is a perforation or when there is chronic obstruction, the bowel is edematous. And one contraindication for the use of staplers is edematous bowel. So avoid staplers in these two situations, because you are likely to end in trouble. You are likely to have anastomotic leakage and miserable problems after that in an already compromised patient. So hands-on anastomosis, traditional, probably much better than the use of staples. Thank you.
Regarding the second point, tissue, I think if we are going in only for diagnostic purpose, we must take as much and as many tissues as possible. So I would say multiple enlarged lymph nodes, the larger ones, omentum, a piece of omentum, a piece of parietal peritoneum from the abdominal wall, and some people say even a liver biopsy. So because it should not be that even after laparoscopy under GA or laparotomy, we say that we don't have the diagnosis. So all this should be taken. And the third point which Dr. Sitaram mentioned, no stapler. And if there is any doubt, no anastomosis. just bring it out as a stoma and distal mucous fistula and let the problem be handled at a later date. TD, any concluding points? Otherwise, we can close. It is 9.
Yes, sir. I think we have tried to cover each and every aspect, and as I have described that we have to be very, very careful in unlike any other abdominal situation, in especially in adhesive obstruction and cocoon formation. As sir said that our aim, we should pray that we should not be making any enterotomy while entering and while doing our adhesiolysis. That is the final message. Thank you.
So, as I posted in the chat, I am very happy to see that yesterday's session already has had more than 300 views on the YouTube. So I'm sure that the efforts which all of you are making are benefiting students and practicing surgeons. So with that, I would like to thank today's speakers. And
Sir, there is a question on YouTube, sir.
Yes.
By Dr. Nimesh Tiwari.
Yeah, please,
good evening,
take
sir.
that.
Yes, sir. Good evening, sir. What will be the treatment option in peritoneal tuberculosis if patient has already completed the treatment for 1 year and got recurrence within 6 months? So first of all, the chances of recurrence is more in clinical care, clinical suspected case, or histological proven, but not microbiological confirmed case. First thing. Second thing, before that, the recurrence is more in if the patient is not taking antitubercular therapy in proper dosage form. Suppose the patient is having weight of 60 kgs and he is taking antitubercular therapy of the 40 kg of the patient, the chances of recurrence increase. So the first reason is the patient was clinically confirmed or radiological confirmed, but not microbiological confirmed. Second thing, dosage form. Third thing, the patient, most of the patient, they are not taking their treatment properly. Either they have some drug-induced hepatitis or they have drug-induced vomiting, they have recurrent nausea. So they just threw out their drugs out of the window. So we need to ask first of the cause of recurrence. Fourth thing, the risk factor associated with the abdominal tuberculosis. If the patient has the risk factor of patient having HIV or patient is consuming alcohol or patient is having diabetes or CLD or CKDs, these types of the patients have high chances of recurrence. So before starting of the ATT, if the patient got recurrence, try to find out the cause of the recurrence. Don't start the ATT abruptly. Just the patient comes to you, he had a history of the 1 year of treatment. Second, there is no guidelines which says you can extend the treatment for 1 year. So find out the cause. Why do you extend the treatment for 1 year? Is there any complication was there? Patient was not responding, or patient has intermittently drug-induced hepatitis and you are modifying the treatment intermittently. So find out the cause of recurrence, find out the factors behind the recurrence, then you will start the treatment again and confirm. So if the recurrence you are suspecting, strongly suspecting recurrence, then confirm the case either laparoscopically or either radiologically or any way.
So thank you everyone. Thank you Dr. Sitaram for joining on both days and hope to see you in more sessions of Jaipur Surgical Tutorial. Thank you. Good night everyone. We will close the session. Good night.
Good night, sir.